to introduce myself, my name is Berkeley Greenwood. I work for a company called Decidium. Decidium is what is known as a market access agency, or a value access agency. So what we do is to work with different organisations to try to understand the importance of particular healthcare interventions. So this can be anything from pharmaceuticals, medical devices, vaccines, diagnostics. It can include procedures, so particular types of surgical intervention. It can include, for example, robotic surgery, all and everything. So we're basically interested in the mechanics of what causes the system to decide to use particular interventions or not to. And one of the elements of that is NICE, which I'm going to talk to you about today, but there are in fact many others. So NHS England uses NICE's advice a lot, but it has its own appraisal processes and review processes. Tied up with market access is government relations, which is in fact where I started 30 odd years ago. I worked for one of the political parties and continued along that route for quite a long period of time. In fact, until the NHS started to take over the decisions about what to spend money on, the main focus actually was political rather than NHS England. But in the last 10 to 12 years, there's been a gradual drift. So the only decision really that is now political is the matter of affordability. So what do I mean by affordability? What I mean is what a country is prepared to spend on its healthcare system, and whether ultimately it wants to spend in broad areas. But it's for the NHS to decide on the detail and what it spends in the detail, down in the reeds. And it's the down in the reeds bit that, generally speaking, I'm mainly interested in. The ability to affect the global healthcare budget is, of course, limited. That's operating on a much bigger political level, which is not really so much what I'm interested in these days. But NICE is a fascinating body. It's been around since 1999. I'll talk to you a bit about what it does. I fell into this piece of work really by accident because my main driver was political, but I'd studied economics. And one of the subjects within economics I studied was health economics. This was in the late 80s. And there was a concept which I'll talk a bit about today called a QALY adjusted life year, which was much the chatter of health economics. And the QALY has lots of faults. And so I made a judgment back in 1987 that health economics sounded to me like a pretty much voodoo science. And I wasn't probably going to spend too much time concentrating on something as shonky as a QALY. So health economics was not the way to go. I could not have made a big mistake because the richest people that operate in pharmaceuticals these days are the people who run the health economics agencies. Sadly, I'm not one of those. I deal with the advice element of it, but I'll talk to you a bit about all of that. But it's interesting that over 35 years, it's gone from being quite shonky to being a very established part of the way that decisions are made. And so it's a really, really integral bit of whether particular interventions are made or not. Now, we've got an interesting thing coming up, which is that NICE will shortly review a new product in the area that you're all interested in. And there are many opportunities for the public and for patients to participate in those processes. Now, I'm a consultant. I don't work for the company that produces that product, but nonetheless, I'm not allowed to talk about the product in any great detail, so I'm not going to make any comment about whether it's a good or bad product. That's for you to decide. What I will tell you is about the framework and the process that the system uses in order to make an assessment about whether the product is worth spending money on. So that's what we'll focus on today. So HTA, Health Technology Assessment, very broad concept. What it really does is to decide on value. Is something offering value to the system? Is it worth spending money on? And there are a variety of different measures that are used for this. But the reason why you do this is to decide whether to fund something or not. What you're trying to produce is safe and effective healthcare policy. So the thing that, and it's interesting what the NHS means by that, because our instinct on that safe would mean you don't kill people or you don't damage them in some way. What the HTA process often means by safe is not that at all. What it means is that it's making a secure decision financially. And it's not making a decision that's going to end up spending large sums of money inappropriately. So quite a lot of the engagement and the negotiation I have with NICE is to persuade them that the NHS is making a safe decision funding-wise, and that we can be reasonably sure, certainty is a really key word here, we can be reasonably sure that this is a good use of NHS money and what they're seeing is what they're getting. But ultimately, common sense would tell you this is about whether treatment A should be reimbursed in the NHS, for which patients should it be provided, and for how long. So what it might look at is it might look at clinical efficacy, it might look at actual safety, and by that I do mean whether you damage people by providing the product. It's really more for the licensing body, EMA or the MHRA in the instance of the UK body. A lot of what we do is, what my agency does is, obviously we want to get the products that we're working over the line that we believe in, and that's part of the process. But then the second stage is usually to have an implementation program of some sort. I have to say that actually, there are occasions where you just don't think a drug should get over. I've certainly advised companies in the past that you've got a cat's chance in hell of getting through nice on this. Don't even try, because you're just going to make yourself look silly. Or quite often we're brought in at a fairly late stage where the company has not made a good not really had a good handle on it, and you're looking at the evidence and thinking, how on earth did they ever think they would get that through? So, I have some sympathy for what NICE has to deal with, because they do have to deal with some pretty rubbishy applications. Bits of terminology which are quite important in terms of running through the process. Utility, utility literally means usefulness. In economic terms, it means the measure of the preference or value that an individual or society gives to a particular intervention. So the most widely used measure is the QALY, which is the Quality Adjusted Life Year. And what that means, essentially, it means it's a scale from 0 to 1, with a lot of decimal subdivisions in between, where 0 is death and 1 is perfect health. So the average person probably has a QALY state of around about 0.88 to 0.89 at any given time. Actually, it's not a linear scale, in fact, so by the time you get down to about 0.5, you're probably not in a great state of repair. So the difference between 0.5 and death is quite rapid once you start to decline. But what you're doing is trying to measure with an intervention how much the product, whatever it might be, increases you, moves you up the scale from where you were, and let's say you're really quite ill, so you've got a QALY of 0.65, and the product provides an extra, let's say for the sake of argument, 0.2, and it gets you back to 0.85, you're going to be a hell of a lot better, because you're not going to be that far off the average health state. You're going to be a hell of a lot better than you would have been if you've got a QALY of 0.65. So one of the things that we want to know is the utility, literally what the product does to move you up the scale. And that is a really, really key and important measure of what a healthcare intervention is doing. And what you then do is you look to see what the incremental cost is. So an increment is the extra bit that you add on to what was already there. So if the cost of a particular treatment of a disease is, let's say for the sake of argument, £100,000 a year, and the product costs £120,000 a year, but in spending the money on that product, you remove all of the costs you would have had previously. You've got the previous 100,000, you've got the new 120,000, so the incremental cost is the difference. It's the £20,000. So that is the extra cost that the system is interested in. And then you won't be surprised to hear me say that what we want to know is, for that extra cost, how many QALYs do you buy? So you look at the additional QALYs, you look at the additional cost, you divide the one into the other, and that's where you get your ISA from. And that's the figure that the system is interested in. What the system is not very good at is capturing social cost. So carer costs and things of this sort. And it's tried. But let me give you an example. So if you have a situation where the country has less than full employment, and full employment is about 4.5%, so the UK is pretty close to having full employment. If you have less than that, so it's, let's say, 5.5%, you've got 1% of extra people kicking around who don't have jobs and are available to do a job of work. And let's say they're evenly distributed around the country and that they have pretty much the same skill set. If you have a product which allows you if you have a person who's ill, and as a result of their illness they can't work and they have to have a carer, and that carer has to give up work, is that a societal cost or not? Now the answer is, of course, it is, because there is a utility loss that applies, literally a lack of happiness and feeling good about yourself that applies to the fact you can no longer work and that the carer can no longer work. So you've got both of those. But what happens, of course, in both of those instances is you free up 2 jobs. So you've got some benefit costs kicking around, but these people will go on to benefit, but the 2 jobs that have been opened up will be taken by 2 other people. So they get a gain in their utility because they feel better because they've got a job, and they're no longer having benefits, and so it balances out. So the societal cost might be 0. It might not be, because if the 2 jobs get freed up in, let's say, Cornwall, and you live in Newcastle, and people don't want to travel, you may end up having 2 vacancies you can't fill, and there may be a cost to the economy, but we don't know. And the other thing is, the only other real cost that comes into this is training, which is, were the 2 people who had to give up work, who were replaced by the 2 people who were unemployed, did they have the same skill set? And if they didn't have the same skill set, obviously these 2 people will have to be trained, and they will have a cost attached to that, but we don't know that, and we don't know to what extent that training would take place, so you can't estimate it. So we know, actually, in reality, that some of the, the fact that they're in different places, the fact that training is different, the fact that you might end up paying more benefit here and giving up less benefit here, we know all of those things are likely to be the case. So the chances are that there is a cost to illness, but we don't know what it is and we can't estimate it.
So one of the issues about this condition is that it's a dietary management thing, largely, because that's the only kind of proven approach. And the cost of eating only stuff you can eat is huge, socially and kind of psychologically and all of that, but there's no actual financial cost to that. So how does that get measured in this system? So
this is where the utility values come in, which is that your preference as an individual and the people around you, who support you and are bothered about the fact you can't eat what you want to eat, that actually we recognise as a detriment. So we know that that has a negative cost. For society as a whole, for you as an individual, we know that's a cost.
So there's a big issue for patients to actually really to describe what's the impact of managing or kind of managing that diet.
Now here is a really, really important point, Jill, which is going to be absolutely key for the way that this drug is assessed when it's assessed, which is, how do you measure how bad the fact that you can't eat is? And what we will try to do is to put a value on it, and that value might be, for the sake of argument, 0.05 of a QALY. So instead of your being at 0.9, you're at 0.85. It could be more. I'm just taking that as an example. Now, the way that that's estimated is that you can do this in a number of ways. So typically, when you're treating someone with the drug, you ask them what they felt their health state was at the beginning of the treatment, and as they go through the treatment, do they feel better? Did they get side effects? Did they have any adverse events that were particularly severe, not just sort of kind of vague side effects, but real events? Did it free them up and allow them to eat more? Did it change how they felt generally? So some of those will be negatives and some of them will be positives. And you ask them first and then at the end and at stages in between to see what that progression is. And this uses a scale known as EQ5D, which is the European 5-dimensional quality measure tool, EQ5D. There's another version which is called SF36, which is a 36-dimensional scale. So you're using these instruments to try to work out, so it'll include things like pain, tiredness, actual health, etc. is all built into that scale. There is a reason for boring you with all of this technical detail. Now, so you probably have a view. You could go onto the treatment and you'd be measured and you'd know what the difference was before and after. But supposing that you have been dealing with dietary issues for 25 years, you've kind of got it sorted, you've got your routine, it's part of your life, and the reality is you just get on with it, which is what I suspect, having heard you all talking today, is what most of you probably do. When you do the EQ5D measure, you are likely to underestimate the extent of the effect on your life at the beginning of the process, and so you will rate it higher than it actually probably is. Whereas somebody who came naive to the treatment who just got the disease and wasn't used to this, would probably say actually that they were in a worse situation than you think you are. And what that means is when you measure at the end, the actual gain you appear to get, instead of being that, is that. And that's a real problem, Because as I've said, the quality is the thing. You want to try and get as many quality gains as you possibly can, because when you divide that into the incremental cost, it brings the cost down. So the bigger it is, the lower the incremental cost will be. And if actually the effect of the EQ5D is underestimating the real gain that you're getting here, it's going to make that incremental cost look like that instead of that. And that's when the system tends to say no.
So there's something about the patient thinking about exactly, because it's hard to know if you've grown up with something, exactly what it would be like to not have to deal with that.
Yeah.
So, but it's about comparing yourself to somebody who isn't restricted in the same way.
Exactly.
Thinking about the
That's
impact
exactly
of that.
right.
So the other question I have is that I've looked at qualities, at the EQ5D, and I think I'm right in thinking a lot of the questions about can you wash yourself, can you, which
exactly.
has got no relevance to advocacy.
You're absolutely right.
And that worries me. Really.
So the only thing you can do under those circumstances, and I'm just trying to think how the company has captured its utility data, which is what we're talking about here. That's the shorthand version of what we're talking about. You can use other types of tools. So you can use SF36 or variants of that, or disease-specific tools, and you can map across to EQ5D. But the reason why I'm so hung up on EQ5D is because that is the measure that NICE absolutely clearly wants to be used. I think you need to be really clear about what the actual impact of this disease is, because when you come to give advice to NICE, and quite surely people in this room will be the people that NICE will call on for advice during this process, you need to be really clear about what the impact of this disease is. And it might be that you say yourself, actually I've learnt to deal with it, but I represent a large number of patients that don't handle it as well as I do. But the key thing is that people on that committee understand the severity of the disease and the impact of it.
The trouble is the medication they're bringing out, they're actually saying you still need to follow the same dietary guidelines. So they're not distinguishing. And therefore, in a sense, they're not saying, well, you can take this medicine and you don't need to worry about the diet anymore, you've got freedom. You've still got the same dietary treatment.
So Dorian, this is where I need to be very careful, because I can't comment on the drug and I can't appear to promote it. No, I understand exactly what you're saying. I understand what you're saying. My point is this. To my knowledge, it does not displace diet, the dietary issue, but there are other factors of the disease which have huge utility disbenefits. And I'm not going to make any comment about whether I think it deals with those, but pancreatitis is clearly one, where you would potentially get very large utility decrement. But the problem with that too is that, I think, Jill, you've clearly got a good understanding of the way the EQ5D works, which is great actually, because I think getting your head around that is really important in dealing with this. Because it's a scale that measures over time, and even if you do it intermittently, the gaps tend to be quite lengthy. You can easily have a pancreatic attack in the middle of one of the measurement gaps, and it won't reflect at all on the EQ5D. Despite the fact that pancreatitis is painful and it's unpleasant, and EQ5D captures that, you wouldn't see it on the EQ5D. So that is another challenge. Please.
It's just important to mention that that's one of the things that is trying to be captured in the burden of disease surveys.
The drug being reviewed will give you an extra 3 months of life beyond what you would normally expect. Then the end of life criteria is applied and the ISA goes up to £50,000. And then you come to the new HST process, which has been going for 2 or 3 years now, and that is where you get the ISAs of 100,000 to 300,000. So Jill, it's not true to say that they don't still go through this process. It's much more subjective than the single technology process tends to be. It doesn't apply the rules quite as rigidly or quite as hard, but it does apply them. And up to 100,000, they will want to see a gain of up to 10 QALYs. Now, what isn't clear is if you only get 2 QALYs, would you still get the 100,000? So there's quite a lot of subjectivity. So if you're not getting a load of QALYs here, so this broken toe thing is only giving you 2 QALYs, and how much of an unmet need is that in reality? You're getting a bit of arthritis, but it's not really severe arthritis. Is it really that much of a problem? Do we think on that basis, if broken toes were really rare, that the committee looking at that would say, well, you know what, 2 ISAs, I think it's worth giving it a 100,000 threshold. My guess, and it's untested, is that they wouldn't. I think that they would say, no way, we're not funding that. But theoretically they could. And if you're getting 10 QALYs, then you should get the 100,000. Above that, you pretty much need to get 1 more quality adjusted life year for every £10,000 of additional headroom they give you, up to 300,000. So to get the 300,000, you need to be getting something like 30 QALYs. So I've worked on nearly 200 NICE appraisals, And I have seen more than 15 QALYs only on 2 occasions that the committee agreed actually existed, as opposed to the company saying, we think, there are all these QALYs. So they're very, very, very rare. And usually what you see is the manufacturer will say there's 18 QALYs, and NICE will say, no, there isn't. There are 5 or 6. And they might end up compromising in the middle. But to end up getting 30 QALYs, I've never seen it, and I think it's extremely unlikely that many products will ever do that. 3 or 4 maybe, and those products will be ones which you give probably to deal with childhood diseases where you're getting years and years of almost perfect life to follow. So these will be curative drugs used in children typically, I think, that are most likely to get the 300,000 headroom. So it will be a tough criteria to satisfy. For most rare diseases, you're going to be looking at 100 to 150,000 as the likely threshold. Is that clear? Great, so that's what we're up against. You can come up with a nicer figure of 120,000, but you've got tiny patient numbers in the studies. So do you really believe what you're seeing? Particularly usually in terms of long-term effect, because you get lots of the QALY gain in the tail. The long-term effect is where you're going to get a lot of that gain going out a few years. And how can you be sure that what you're seeing there, given that you're essentially extrapolating on very small patient numbers, how can you be sure that's really a true effect? So you have a huge amount of uncertainty. And where there's uncertainty, you tend to get no's out of the process. So a big challenge for us is to try to get the best data, particularly the quality of life data is often very uncertain. Try to get the best EQ5D data we can to try to deal with the uncertainty there. Try to get as much studied data as we can to try to reduce the uncertainty there, and try to get a really good grip on the costs that you're displacing, so you're avoiding out of the system, and have a really good deal of certainty there. But you're absolutely right, there's a vast amount of uncertainty, and the rarer the disease, the more the uncertainty usually. HST, this committee, was specifically set up because they know this is a problem.